Hello and welcome to Chapter 2 for our Abnormal Psychology course. Today we are going to cover a few different things. So we're going to talk about, well, generally we're talking about diagnosis and treatment, okay? We're going to talk about the experiences of the client and the clinician. We're really going to focus on the DSM, okay? We're going to get lots and lots of information on that. And then we're going to talk about the steps that are in the diagnostic process and a little bit about treatment, okay? So, as I did last time, I'm going to go ahead and keep all my stuff up here so that you can see, where we are as we go along with PowerPoints. All right. So, here's just terminology. These beginning chapters are chapters where if you already know this stuff, great. This will be super easy for you. Just hang in with me. Hopefully you'll learn something new. If you know nothing about this yet, I hope you learn a lot. There's good terminology. There's a lot of information that's good for this, as well as always, I care about critical thinking and all of those kinds of things. Okay? So, just starting off with basic terminology. Now, your book differentiates here between what we call a patient and a client. So they would say a patient is a person who receives treatment in general. A client would be a person seeking psychological services. Now, when I've worked in different environments, we actually call people different things. So when I've worked in hospital settings, we call people patients. In my practice and most outpatient kind of clinics, we call people clients. It's really a personal preference. It's really the institution's preference. So that changes a little bit. But calling people a client is sort of that language that reflects the view that people in treatment collaborate with those who treat them. Okay? They're not just a passive recipient. They are not just a patient, but they are somebody who is working with the therapist. Okay? So a psychologist, when somebody uses the term, I'm a psychologist, they really are only supposed to use that term if they are have a doctorate degree, so a PhD, or there's a degree called a PsyD, which is a doctorate in psychology, versus the PhD is the doctorate in philosophy, but within psychology. But generally, we have the healthcare profession offering psychological services. So let me be more specific. I call myself all sorts of things in this job. So sometimes, we may call ourselves a clinician, but a clinician just generally means anybody providing treatment. So you might call a medical doctor a clinician if they treat patients. A therapist is a clinician, any of those kinds of things. Now, here's really what I want you to know the difference. I want you to know the difference between a psychiatrist and a psychologist. People get this mixed up all the time, and if you've taken this course, I really want you to be able to go out into the world and know the difference between a psychiatrist and a psychologist. So a psychiatrist is a medical doctor. They have gone through medical school, and then they specialize in psychiatry, okay? They can prescribe medications. Some do some therapy. A clinical psychologist, that's what I am. I have a PhD, but again, you can have a PhD or a PsyD, is a mental health professional with training in behavioral sciences who provides direct service to clients. So the psychologist typically does therapy. Some do, of course, if you're a clinician, you do therapy. Some, of course, do research and teaching and those other things. In case you're interested, the difference between the PhD and the PsyD is simply that the PhD is going to have more of a research focus and the PsyD is going to have less of a research focus. And there are other differences, but we'll just stick with that for now, okay? If you're going into this field, you really do want to know, before you choose one of them, pros and cons of each degree. Okay. So like I just said, there's two types of doctorates in psychology, the PhD and the PsyD. Then there are therapists, counselors, social workers, marriage and family therapists, all sorts of things, school psychologists. A lot of them have master's degrees. Some of them have PhDs in counseling or in marriage and family therapy or things like that. But typically these people have master's degrees. And typically they're referred to as a therapist or a counselor. They should not be referred to as a, quote, psychologist. Now, in my practice, I often have people that come in and will say like, oh, well, so, you know, they call me a counselor and then they say, oh, sorry about that or whatever. I personally don't care, but I know that a lot of psychologists do care and they want people to recognize their title of what they are. Like I said, I don't care at all. You can call me a therapist, a counselor, a psychologist. Just Andrea is fine. I'm very comfortable with whatever it is, as long as we're being productive and helping people change and improve their lives. Other people are not as flexible. So it's good for you to know the difference in these titles and degrees so that you will understand who has what and what to call them. All right, moving on, okay? So most importantly in this chapter, we're really focusing on the DSM. The DSM is the Diagnostic and Statistical Manual of Mental Disorders. If you go into this field, you need this book. You need to know this book. You need to have this book. For this class, and I said this before, you will need access to this book. So that you can do the last 2 assignments. Okay, and again, you can get it online. You can borrow it from a friend. You can have a friend screenshot you the page you need. You can, any of these kinds of things. Show up at a bookstore and, you know, read over what you need. Anyway, the DSM, the current one is the DSM-5, and it's a purple book. So let's talk about how we got to where we are with the DSM 5th edition. So this book is published by the American Psychiatric Association. It contains these standard terms, standard definitions of psychological disorders. Okay, psychiatrists and psychologists contribute to the research and decisions that are made when these books are put together. As a description, we call the DSM-5 a non-axial diagnostic system. I will explain that in a minute. It's divided into 22 chapters and includes sets of related disorders. Okay, now let me sort of explain how we got here. The very first edition was published in 1952. It was a small book and it had really general descriptions of things. We moved on from there, and the edition that is before the DSM-5 is the DSM-4 TR, which means text revision. That is a silver book if you see it out there. This was published in 1994. Well, the DSM-4 was. The text revision was published in 2000. I always remember the books by the colors. The text revision is silver. The 1994 edition is actually like a maroon color. Many texts and research articles are continuing to use the DSM-4. So while I think your book and any current book doesn't focus as much on the DSM-4, I am going to talk a bit about it in this chapter. Here's why. If you go to work in this field or any related field, the majority of people are going to be older than you. And the majority of the people have been trained in the DSM-4. They still use the DSM-4 language. As you may see from the article that I had you guys read on the DSM, there's a lot of people that are unhappy with the DSM-5. There are actually people that have decided not to use the DSM-5. Now, if you submit for insurance claims or things like that, you need to use the DSM-5. But because there are so many people that are not on board with it, or there are so many people that were just trained in the previous edition, I do think it's important for you to understand some things about the DSM-4. Okay, now that current edition was published in summer of 2013. So you're really getting the most updated information in this class. Now, I mentioned an axial system in the past. And by the past, I mean like 2 slides ago. So the DSM-5, as I said, is a non-axial system, meaning when we give a diagnosis, and that's sort of over here, these are not actually in separate categories in the DSM-5. When we give a diagnosis, we just simply list psychiatric diagnoses and medical diagnoses and psychosocial factors and disability factors, and we all just kind of like list them together here, okay? In the DSM-4, and again, this is important for you to know, there was a 5-axis system, a 5-axis system. And this is how you did a diagnosis. Axis 1, you put clinical disorders, so things like depression, schizophrenia, stuff like that. On axis 2, you put developmental disorders, so at the time, mental retardation, which is now called intellectual disability, and personality disorders. The idea was that axis 2 disorders were unchanging and things that people would live with throughout their lives. We have different ideas about that now, but at the time that's what we did. Axis 3 was any general medical conditions. That should be pretty self-explanatory. Axis 5 was psychosocial and environmental problems. So we would say problems related to recent divorce or problems related to educational disparities, things like that. Axis 5 was something called the GAF, or the Global Assessment of Functioning. And this was a number that you put from 1 to 100. It was really subjective, in my opinion. They had all these specifics on how you were supposed to decide if the person got a GAF score of 53 versus 63 versus 73 or whatever it is. What I found when having different supervisors is that honestly, you kind of learned how to pick the number that your supervisor would pick. And then when you went on to the next supervisor, you kind of had to change things up. So we've done away with the GAF score because its, reliability was not very good. It makes life so much easier for you guys not to have to learn how to do a GAF score. But you do want to know these things. You do want to know that there was a 5-axis system and that now this looks like it puts it in categories, but there aren't really categories here. It's just saying we just shove them all over in this same thing. Okay, moving on. All right. So the DSM-4, TR, and 5 are based on categorical classification. Okay, so categories. And this is what we call a medical model. Okay, so medical model. Medical model basically means you're in or you're out. Okay, so that is if you have a minimum number of symptoms, you're diagnosed with a disorder. If you're short even 1, you're not diagnosed with the disorder. Honestly, there's little research to support this diagnosable threshold. And we do use this NOS category, more so in the DSM-4, but some people still use it now. This NOS meaning not otherwise specified for what we call sub-threshold cases. Now the DSM-5 actually has these separate diagnoses with different terms to say, hey, this person has some of these symptoms but doesn't actually meet criteria. So for example, if I go to diagnose major depressive disorder, a person has to meet, let's say, I can't remember, let's say 5 out of the 11 symptoms listed. If they meet 5 or more, they're given a diagnosis of major depressive disorder. If they meet 4 or under, then we say, nope, they don't have the disorder. Now, I get it. You have to have some sort of threshold. You have to have some sort of classification in order to communicate with other people this person is really suffering from depressive symptoms. However, when I have clients come in, even if they don't fully meet criteria, if they're struggling, I'm going to treat them in the same way as somebody that I would treat that had 5 symptoms versus 4 symptoms. Okay, so this is known as the medical model. I do want you to know that term. And that this is this class, why am I struggling with that word? Categorical classification. Okay, next. So this we already kind of said. This changes in the multi-axial system. That is that there were 5 axes in the DSM-4 TR. And actually, I don't know why this says change to 2 axes. That should not be there. We say none. So we say no axes. Sorry. None in the DSM-5. However, the reason that they say that is simply because we say clinical syndromes, meaning all the stuff, and then at the end you can put in psychosocial and environmental problems. You don't actually put it on a, quote, separate axis, but you sort of stick them in there at the end. Okay. I hope that didn't confuse you too much. Hope I clarified that. We have these changes in the organization of diagnoses, okay? So we had the DSM-4 clusters of diagnoses on similarity of symptoms. Now the DSM-5 reorganized some things. It really reorganized to reflect new knowledge of comorbidity and new knowledge of shared etiology, okay? For example, obsessive compulsive disorder. Obsessive compulsive disorder used to be in the anxiety disorders category, okay? It now has its own category. So we now have a separate obsessive compulsive disorders category. And in that category, we also put hoarding and body dysmorphic disorder. So these are now considered obsessive compulsive disorders versus obsessive compulsive disorder just being another anxiety disorder. I think that this is a fabulous change because, interestingly, we treat most anxiety disorders with the same methods and the same medications. Obsessive compulsive disorder, we treat with different methods and different medications. So to me, it makes sense that this is separated out, and it makes sense to me that it is put with hoarding or body dysmorphic disorder. As we learn about these diagnoses through the semester, I hope this makes more and more sense. Okay. This is just kind of a fun table. This is a description of mania in the DSM-2. So up here, this is it. It just gives a little description versus the DSM-4 where we have these criteria. So throughout the semester, I will use the word criteria. When I say criteria, I mean these things, okay? So A, B, C, D, E, these criteria. Under B, we have, 7 different criteria that, you have to meet 3 or more of these. So do make sure you understand what the word criteria means. Do make sure that when you look in the DSM to do your assignments that you find a chart that looks like this, so that you'll list out all the criteria for that particular disorder. Okay, but you can see from here, from the DSM-2 to the DSM-4, we've changed dramatically. All right, I do not expect you to be able to see this page very well. You're welcome to zoom in on it, but the idea here is just simply how categories changed from the DSM-4 to the DSM-5. For some of them, it's just simply a name change. For some of them, we moved disorders from one category to another category. For some of them, we split one diagnosis into several different ones. So things sort of changed, and we added some things. Okay, you do not have to memorize all the differences from the DSM-4 to the DSM-5. Things I do want you to memorize is that the DSM-4 was a 5-axis system. The DSM-5 is a non-axial system. I do want you to understand that category changes have been made. I do want you to understand that we still, in all of these, use the medical model, which is categorical. Okay. So some other just changes in the DSM-5. Again, these are things that are important to know just if you converse with people who are used to the DSM-4, you will understand their language also. Okay, so personality diagnoses actually remained unchanged. They had in the old DSM this section for further study. We continue to have that. There was an idea and a belief that the categories for personality disorders were going to change in the DSM-5, and they actually did not. Okay. We have new diagnoses here. We have something called disruptive mood dysregulation disorder. We have premenstrual dysphoric disorder, and some things like that. We'll learn about those in our depressive disorders section. Okay, we've renamed some diagnoses. So people used to use the term mental retardation, and now we use the term intellectual disability. Again, I like to point this out because when you speak to other people, they will continue to use the term mental retardation. And in our assessment measures that we use that test intelligence, they are still classifying mental retardation. It's a term that is used not in a pejorative or derogatory way, but just as a label. So because the world has started to use this term in a negative way, we've changed it to intellectual disability. But you'll hear both, okay? Another one is dysthymia. Dysthymia is now called persistent depressive disorder. And actually persistent persistent depressive disorder now includes dysthymia, as well as another disorder that was thrown in there. And we will talk about that again in the depressive disorders section or mood disorders section. Okay, some places we combine diagnosis. So substance use disorders, that's what we call it in the DSM-5, a substance use disorder. In the DSM-4, we differentiated between substance abuse and substance dependence. And frankly, it was really a difficult thing to do. And it was kind of a category that was confusing. So they've made that better. And generally, we have clearer criteria. And that is the goal for each time we renew the DSM, each time we upgrade to a new edition. One of the main goals needs to be clearer criteria. Okay. Here's just a list of the disorders in the DSM-5. You can pause this, you can look at this, you can look at it in your book. It goes on here. Again, you do not need to memorize all of these. We will talk about all of these. But if you want to just take a quick scan for fun, absolutely take the time to do that. Pause me and restart me when you're ready. Okay. I do want to mention what the ICD is. So if now you know what the DSM is, you'll also want to know what the ICD is. And I believe, we're on the ICD-10 now. And this is, again, just a book of codes. But this is what people, outside the US and Canada tend to use instead of the DSM. Also, it is a list of all medical and psychiatric diagnoses. Okay, it is a lot. But for each thing, it has a particular code so no matter where you go, if you go to Canada, if you go to Brazil, if you go wherever, you can have a number, a code number, and then you can look that up and know what kind of a disorder people are talking about. It basically gives us all the same language, the same book. All right. So it gives us this common diagnostic system. All right. Okay. So cultural considerations and ethnic considerations. This is really important. So what we need to know is that a lot of the original research actually for a while, all of the research that was done on mental health, on anything, was done with white men, frankly. And from there, we have started to look at disorders with other genders and with other cultures and race and ethnicity and all of these factors included. And what we see is that mental health issues are often displayed in different ways, depending on age, depending on culture, depending on whatever it is. Some people talk about, well, my stomach hurts. Some people call it anxiety. Some people refer to, they use different terminology. They're also different in what they're willing to report or willing to seek help for. Culture can influence a lot of things. Risk factors, types of symptoms experienced, willingness to seek help, and availability of treatments. Okay? So the DSM-4, again, going back to the DSM-4, talked about really needing to enhance cultural sensitivity. And it had this appendix of 25 culture-bound syndromes. These are, well, some of them are quite interesting because they are not seen here in the US. Here is a list of just a few that were there. If you want to, for fun, look them up. So just so you know, like the DSM-4 had these specific culture-bound syndromes. Currently, in the DSM-5, they don't really talk about them as separate syndromes as much as we now kind of discuss things in cultural context and do note if there are specific symptoms that we're seeing based on that particular culture. Okay. So again, in that article that I had you do your first discussion on, there's a lot of criticisms of the DSM in general. There's a lot of criticisms of the DSM-5. People always criticize new things, but I think that they have some points, and I also think that there's some benefits to diagnosing. So are there too many diagnoses at this point? Is it basically that we're pathologizing everything? Okay. Another thing that we need to address is comorbidity, and we will come back to this word later in this chapter. But comorbidity means that there's a presence of more than one diagnosis. If we say, well, this person has depression comorbid with anxiety, it means that they have both things at the same time. So the presence of two or more diagnoses, comorbid. We see one of the main research studies, and I do want you to know this name. It's the National Comorbidity Survey. So with the NCS, if you will, this was a huge study that collected data on an enormous amount of people. And the idea was they really wanted to look at substance use. So it did look at addiction and substance use, but then also looked at comorbid disorders. And what they found is that about half of the people that said that they have one disorder ended up meeting criteria for a second disorder. So many people have comorbid diagnoses. The DSM kind of gives us this question about reliability in everyday practice. How well are we doing at actually giving diagnoses? Just these types of things. So in just a moment, we're going to move on and talk about reliability and validity. But I do want to say that I think that there's a lot of positives to diagnosing and there are negatives to diagnosing. Some of those negatives to diagnosing are stigma. That is that if you have a label, that people may treat you differently. Some people don't want a label on their, insurance, or it could cause problems if you try to get life insurance. Up until recently, a lot of people were denied health insurance coverage due to having a mental health diagnosis, or which is a pre-existing condition. So basically, if you came in and you tried to get health insurance and you had any type of depression or eating disorder or schizophrenia or whatever, that insurance company could say, no, nobody's going to cover you. You just don't have health insurance. That's not allowed now. You can't say we won't give you health insurance, but it does change some things. Okay, so those are sort of cons, and there are others. Some of the pros, though, are simply if I see records that somebody has and it says this person has bipolar disorder, they've had it this many times, this whatever, I know what bipolar disorder means. I understand what kind of symptoms this person is probably experiencing without them having to continue to tell me all the little specifics, right? So if we didn't have labels, every time you spoke to somebody else about a client or every time you spoke to somebody else about a research study, you would have to describe the symptoms that the person was experiencing. That could take a long time each time. So it's nice for us to have general terminology. Okay, let's talk about reliability and validity. So again, these are things that you may already know. These are things that may be new. If you already know them, bear with me. If you don't know them at all and you're still confused after this, go to your book, look it up online, get more information. You're going to want to know these things. And hopefully everybody else is kind of somewhere in between and can follow along and learn some things. Also, please remember that when you're watching these lectures, if I'm going too fast, if you need a break, pause me. Start it back up. Okay? Sometimes I go a little bit quicker so that those who want me to go quicker, that works. And then those who don't can take a little break. Okay. Reliability. Reliability simply means the consistency of measurement. Okay? Each time I measure my foot, is it the same length? If I measure it once and I measure, 3 inches, and the next time I measure my foot and I measure 12 inches, I have poor reliability. Okay? If I measure it each time and it measures the same number of inches, I have high reliability. Okay, now within reliability, we have a few different types of consistency of measurement. One is inter-rater reliability. Inter-rater reliability means if I give a diagnosis and somebody else gives a diagnosis to the same person, we should give the same diagnosis. So if the DSM is helping us and guiding us in the way that it should, if I see 5 patients and diagnose them and someone else sees the same 5 patients and diagnoses them, high inter-rater reliability would mean that we agree on those diagnoses. If we're completely off each time from each other, then we have low inter-rater reliability. Okay, ready to move on to the next one? Test retest. Test retest is real simple, right? If I give somebody a measure, let's say I give them a questionnaire about depressive symptoms, if they answer it now and in 5 minutes and in 5 minutes from then, their score should be the same each time. That would be high test-retest reliability. If each time they got completely different things, then we'd have low test-retest reliability. Okay? Alternative forms. Alternative forms is, often we see alternative forms when you have professors that give exams in the classroom. Sometimes they will give 2 or 3 alternative versions of the same exam so that people don't look at each other's papers. Now, you want your alternative forms to have high reliability, meaning that if I get test A, test B, or test C, they're equally difficult and I would get the same grade no matter which form I got. Okay? If, test A had 1 + 1 on each question, and test B used, multiplication and division, my skill set's not as good on those different things. So the alternative form's reliability would then be poor. Okay? So the tests are similar but not identical. And then we have another type of reliability called internal consistency. Okay? And this is now, instead of talking about different tests, we're talking about the same test. So within that test, if I took the first half of it, or if I took the second half of it, I should get about the same result. Okay? So we want it to be internally consistent. I hope those things make sense. If any of those do not make sense based on the way that I described them, please do go look them up in your book. Okay, we're going to move on to validity here. So, validity is how well does a test measure what it's supposed to measure. Okay, so if I have a test and I say this measures depression, and the only measure or the only thing on the test is how tall are you, this would be poor validity, right? Because it would not be testing what it's supposed to measure. All right, so we have a few different kinds here that I want to talk about. The first is content validity. Content validity is the extent to which a measure adequately samples the domain of interest. So for example, all the symptoms of a disorder. So if I create a test and I want it to measure if someone meets criteria for depression or not, if I have high content validity, I will have a question for each of the criteria for major depressive disorder on there. So it would have good or high content validity. Okay, the next is criterion validity. Criterion validity is the extent to which a measure is associated with another measure. We call this the criterion. Okay, we have concurrent or predictive. So that is, if I have, let's say I have a new measure that is supposed to see if somebody has depressive disorder or not, and then I want to make, but blah, 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 but I know that there is an old measure that absolutely is good, then I'm going to give somebody the old measure and my measure. If it has high concurrent validity, both assessments should give similar results. Okay? Predictive validity is that my measure predicts what will happen in a future point. I'm trying to think about how to explain that. In my head, it makes sense. So that is, predictive validity would be, I can give this assessment measure now and know that the results of this assessment measure will tell me if this person is likely to have an episode of mania in the future. You know what? I know a better example. Let's go with this. The ACT and SAT, you remember those? These are tests that are supposed to have high predictive validity of how well someone will do in college. So the idea is that if you get this particular score on the ACT, then it is predicting that you will do well in college and that people should accept you or not, right? Now, let's be clear, I have all sorts of issues with the ACT and SAT, and we will not get into why I actually don't think they have great criterion validity, but you can look that up if you want. The predictive validity, that is generally what it's supposed to be. So hopefully that example helps you know what predictive validity is. Okay, last here we have construct validity. A construct is an abstract concept, right? So while the content validity is not abstract, the construct validity is an abstract concept or inferred attribute. Okay, so it's really a method of evaluating diagnostic categories. So when we look at a whole diagnostic category, does it make sense that OCD is in anxiety disorders, or is it a separate construct and should it be put in a different category? Okay, again, I got to tell you, I love teaching online, but this, when I explain things like this is where it makes it difficult because I can't see people's faces and I can't see if everyone's shaking their head like, yes, we've got this, or if I'm getting blank stares and I need to go over it again. And that's why I say, hey, if you got it, move on. If you don't, go look it up in your book. All right? Now, we already kind of talked about this, so we can just jump right past it. But this is the, criticisms of classification. So stigma, sometimes the categories don't capture uniqueness of a person, right? And this is really where I love my job, and I think computers cannot do my job because each person that walks into my office is different. Each person is unique. Each person is interesting. Each person has a different background. So while I can say, yes, person A, person B, and person C all have major depressive disorder, each person is dealing with it differently, and each person has this issue for different reasons. So the categories don't necessarily capture uniqueness. However, like I said, they do allow categorization, so we have a starting point, all right? This is actually really important to me, and this is that the disorder does not define the person. When you are writing your discussion assignments, or anything that you write, or anything that you say to anyone, please, please, please use what we call person-first language. Person-first language. And that is, Sally is a person with schizophrenia. She is not a schizophrenic, okay? We say, this is a person who is dealing with cancer. We don't say they're a cancerific or something like that, right? The person is a person and has so many unique qualities and so many, pros and cons to them, just like everybody else. And they're dealing with a mental health disorder. So I hope that you understand why that's important. And I hope that you implement this type of language into your everyday language. Okay? A person with bipolar disorder, not, a mania, manic depressive, or whatever people call it. Okay? Classification may emphasize trivial similarities. Okay, and again, we just want to make sure we don't overlook relevant information. I often have people come in that have been misdiagnosed by someone who spent 15 minutes with them and decided, of course, you have schizophrenia. And really, if they had stopped to listen to them, they were just being honest about having some interesting thoughts. They didn't really believe them, and they can think rationally about them. They were just saying like, hey, sometimes I think kind of crazy things, but I understand they're not real. So we don't want to just trivialize things. We don't want to just jump to conclusions. Each person is unique. Each person is fabulous and flawed and all of those things, right? I like to say we all have our own special kind of crazy. And we all just kind of learn how to deal with those things. All right. Ready for the next piece here? You're doing great if you're still hanging with me right now, okay? So these are the steps in the diagnostic process. What we do is we have our principal diagnosis, and that is the disorder that is considered to be the primary reason that the individual has come in. So that is somebody comes in and sits down and I say, so what's going on? What made you decide to come in today? The principal diagnosis. We do something called differential diagnosing, and that is the process of systematically ruling out other diagnoses, right? So when somebody comes in and has like a quote unquote crazy thought, I want to say, okay, is this mania that they experienced this thought in? Is this schizophrenia? Is this stress? Is this depression? You know, what is this? We want to rule out other diagnoses that are somewhat similar. Okay? Comorbid, we already used this word earlier, but for example, major depression and obsessive compulsive existing together. Comorbid. And like I said before, that NCS study that was done looked at those comorbid diagnoses and really looked at addiction, substance use, comorbid with mental health disorders. Okay. From there, we do what you'd call a case formulation. And this is really to gain the full appreciation of the client's disorder. We're going to develop a case formulation. That is the clinician's analysis of factors that might have influenced the client's current psychological status. So now we're saying, yes, we have a diagnosis, but let's talk about why this person has gotten here. What kind of factors are influencing it? What kind of barriers are there to treatment? What kind of, where are we? So looking at the uniqueness. We also want to do a cultural formulation, right? Thinking about the culture's beliefs about the psychological disorders, the ways in which the culture interprets particular events, the cultural supports available to the client. As you go on, if you go on in this field or another helping field, this will make more and more sense to you. Okay, then we create what you call a treatment plan. The treatment plan is simply an outline. It's an outline for how therapy should take place. We want to look at goals of treatment. Immediate goals, short-term goals, and long-term goals. And a good therapist goes through these throughout treatment and says, okay, what goals have we met and where are we going? Is the treatment plan still the best? Are there things that we should alter? Okay? Now, then you want to determine a treatment site. Okay, and I do want you to know that there are lots of different places that people see clients and patients, right? We have our inpatient psychiatric hospitals. This is for people who are typically a danger to themselves or others. Or they need a medication change and they need to do that in a safe place. All right, we have specialized inpatient treatment centers. Those can be specifically for people with eating disorders, with personality issues, with behavioral disorders, with addiction disorders, lots of different things. We have outpatient treatment, and outpatient treatment happens in private practice offices, outpatient treatment happens in community mental health centers, outpatient treatment happens in schools, all sorts of places, okay? If you were to be a student at a high school, the first person you're going to see usually is your school counselor. And your school counselor from there decides if they can help you or if they need to refer you out to someone else. Okay? We have halfway houses and day treatment programs. Day treatment programs are basically, it's like full-time treatment except that you go home and you sleep in your own place at night. Okay, a halfway house means that you have independence. You're not in a locked psychiatric facility, but you live there. Okay. And for goodness sakes, there's plenty of other treatment sites, but we'll stick with these for now. Okay. We want to talk about the modality, and that is what type of therapy makes the most sense. We have individual psychotherapy. We have family therapy. We have group therapy, and we have what we call milieu therapy. Milieu therapy I always find entertaining because it happens kind of typically in an inpatient or halfway house type of setting. And that is simply where people that have disorders hang out together. I think a lot of milieu therapy happens on smoke breaks, or just sitting around in the TV room or wherever that is. And group therapy is going to be an intentional, everybody sits down at the same place and we discuss specific topics. Family therapy is we bring in everybody from the family. The idea of family therapy is that there is not one particular identified patient, but that the whole family dynamic needs altering. Often when families come in, they'll say, well, little, Bobby here, he's the problem, fix him. And we say, we're not going to have an identified patient. We are going to work with the whole family. Okay. In individual therapy, you do have an identified patient. There's only one person in your office. And one that's not on here is couples or marital therapy, something I also really enjoy doing. And that is where two people come in. And again, sometimes the couple comes in and says, so-and-so cheated on me and that's why we're here. Okay, great. We can work on that. However, we're still going to work on the dynamic of the two people, of the couple. For me, I need both people of the couple working. Even if one person technically did something that was, felt to be out of line, both people still need to be working to improve the relationship if it's going to work long term. Okay. Evidence-based practice in psychology. Now, I always say I do therapy based on what research shows works, and I would say that most people do that. Okay. So clinical decision-making that integrates the best available research evidence and clinical expertise. Of course, in the context of cultural background, preferences, and characteristics of that client. But evidence-based practice just simply means research-backed. Okay. Course of treatment. So the clinician's role and the client's role. The clinician's role, quality of the relationship between the client and clinician is crucial. When we look at research to say, does therapy work? The most important thing is something we call common factors. And that is simply, well, it's not simply, but one of the biggest pieces of that is, does the client feel comfortable with the clinician? Is the clinician empathetic and supportive and basically the right personality style for that particular client? Okay. The client's role is to be active. So I always make sure that the client is doing homework assignments in between our sessions, and that during our sessions they are challenged to the point where they're feeling productive in our time and they leave feeling like we've accomplished something and they're ready to go out into the world and be working on things. Okay, last slide here. Outcome of treatment. The client remains in treatment until the treatment runs its course. The person shows improvement and maintains this improved level of functioning. I have some clients that just kind of like coming in and they really enjoy the maintenance of treatment. For other people, they come in with a specific issue, they want to resolve it or improve it, and then go out into the world on their own. Sometimes we have this thing called remission. Remission occurs when an individual's symptoms no longer interfere with his or her behavior and are below those required for a DSM diagnosis. Right, so that would be simply, okay, I meet criteria for major depressive disorder, but then after treatment for this amount of time, my symptoms are low enough that we consider it to be in remission. It hasn't necessarily gone away forever because That's difficult to predict, but it's in remission. And for some people, that is good enough to go on out into the world. For other people, they like to come in for booster sessions. For other people, they like to kind of continue to come in just for maintenance. But all of those things depend on a lot of factors. So do know the word the remission for our exam. I feel like I've talked at you for long enough about a lot of terminology. I hope you soak some of it in. I hope that you do have access to this PowerPoint separately under the Files section, so you can always go back and look at it. And you can always come back and listen to it, and you can always look stuff up in your book. All right, I will talk to you guys in the next chapter.